this group, there are two that I use predominantly. And the first one is called an alloplast, which is a synthetic material, which gives me a great outcome. It gives me a great outcome because it resorbs completely, and it gives me a very, very high percentage of vital bone. But there's another thing that I'm using today in conjunction with this, and that's autologous growth factors. And autologous growth factors can actually make the alloplast more bioactive. And today, the best results I've ever been able to achieve are the combination of the two, what we call composite grafts. Not composite grafts with respect to multiple materials, but a composite graft using an alloplast plus fibrin-based or just platelet-based autologous biologics. And then we get something called the synergetic response. What is synergy? It's the combination of two or more things that give us an outcome that's greater than the sum of the two parts. So there's something about the combination that upregulates cells, in this case osteoblast, makes the bone graft material resorb more quickly, and gets us to good, mature, lamellar, stress-bearing bone that much more quickly. After all, it's about the compression of the wound response and compression of treatment time. Now, in a case like this, I don't care whether it's a long-standing extraction site or extraction immediate implant placement or immediate graft placement, but if we want to place implants in the ideal position, well, we've got to think about restitution of the entire hard tissue complex, including the facial incisal line angle. That means that there's a huge volume of bone. How do we maintain that volume? How do we regenerate that volume? It's certainly easier in an extraction site in a 4 or 5 wall defect. And if we look at extraction sites themselves, we see something very, very interesting. I hope my cursor now appears on the screen. This is a dry skull specimen, and within this, if a tooth is taken out on this dry skull, you will actually see orientation of the trabeculae. This orientation is the very definition of bundle bone. And that's why when we extract a tooth, we like very much to place an implant immediately, because we take advantage of the stress-bearing characteristics of this. But it's not always possible, especially if there's a huge defect or it's infected. And then instead we end up with something like this, a site that a tooth has been taken out, but no biomaterial has been added, and as such, what happens is it starts to heal from the bony walls, and then there's a defect in the center, and that defect in the center allows fibroblasts to grow down, to invaginate down into our site, and then we get a less than ideal volume and a less than ideal composite bone or quality of bone when we're done. So if we select a graft material, and if you're a researcher like me and not just a clinician, but a researcher, academician, we look at resorbable versus non-resorbable, how dense the material is. Is it dense crystalline versus low crystalline versus non-crystalline? That determines what the resorption time is. I want my graft material to be resorbing at the same time autogenous bone is laid down. What type of cellular response? Is it cell-mediated? Is it solution-mediated? Because that determines the pH of the area. Then there were 3 others: quality of bone at the time of implant placement, percentage of vital bone at the time of implant placement, and finally, percentage of vital bone after integration and after loading over several years. Now, if you're a clinician who really is not in the research world, I'll tell you what, I will grant you that the top 4 are not something that is very interesting to you. But the bottom 3 should be, because that determines our clinical outcome. And if we start looking at the different bone graft materials, and there's a lot of them, but perhaps the most widely used, which are alloplasts or non-crystalline HAs, and xenografts or high crystalline HAs, and they could be bovine, equine, porcine, doesn't matter to me. And we look at them, they look very, very different microscopically. But macroscopically, they look about the same. They're all particulate, they're all about the same micron size. But the similarities end there. Because if we look at a xenograft versus an alloplast, people use xenografts basically for 2 reasons. It looks good on a radiograph, and helps you to maintain the volume of regenerate ridge. And I can't think of anything else that would drive someone to use a material that does not resorb. But all of these other things, the rate of resorption, how quickly do we get good stress-bearing lamellar bone so it would accept an implant and then be able to load it very, very quickly? Is it osteoconductive versus osteoinductive? And certain graft materials are, in fact, osteoinductive. What is my percentage of vital bone? What is my mineral density? And what are the rate of complications and failures? All speaks to clinical outcome. Now, this is a radiograph that I actually took from Facebook. So I know everyone out there is very proud of their work. And I know some of the names have posted cases to Facebook. Be careful, because if I find a photograph that I like, I'm going to use it in one of my lectures. And here's a perfect one. This is actually a well-executed sinus graft. It's a well-executed implant placement and restoration. But the caption with this photograph is that this is a 7-year post-op of a sinus graft. So I ask you, if we look at the grafted area in the sinus, is this bone? Doesn't look like bone. It's in fact graft material. And that makes it, if it's not bone, if it's not stress-bearing lamellar bone, the whole apical third of this implant is basically in nothing. It's just a biomaterial, or as the late great Carl Misch used to say, hydroxycrapatite. And here's another radiograph. This is a 3-year post-op of a sinus graft with failed implants. This is what we want to see. This is stress-bearing lamellar bone. This is the appearance that it gives you on digital radiography. And this is a BioOS grafted sinus. And what happened here is that both of these implants actually failed after 3 years of loading. Why? Because when you use a non-resorbable bone graft material and you use it in a place like a sinus, which is poor quality bone to begin with, you only end up with about 35% vital bone. And 35% vital bone is insufficient to undergo the stress of function over a long period of time. This implant just came out like it was never integrated. So if we talk about the clinical outcome of bone grafting, it really should be the regeneration of vital host bone. It needs to become bone, not graft material. So why use a highly resorbable alloplast if we're going to use an alloplast? And what are the biologic consequences? What are the biologic effects of the resorption of a calcium phosphate material? And is there, this is the key question, during the resorptive phase, is there a contribution of the release of free ionic calcium? Let's begin by looking at this BMP pathway. There are 4 BMPs, BMP 2, 3, 4, and 7. There's a BMP receptor on the cell membrane. When any one of these 4 BMPs reaches this receptor, it goes down into the cytoplasm, and then it has a direct effect on the mitochondria, a nucleus of the cell. It helps to upregulate the production of early collagen, which results in the upregulation in the production of bone. But there's something that is just as powerful as BMP and shares some common pathways. And that's it up here in the upper right, which is the calmodulin receptor that's responsive to free ionic calcium. You can see that it shares the same pathway as BMPs. And if BMP is osteoinductive, that then makes free ionic calcium osteoinductive. Now, what is the test? In fact, what is the very definition of osteoinductivity? It's being able to grow bone ectopically, outside of bone. And the classic model for that is to take a material, implant it in dog dorsal muscle, come back a few weeks or a few months later, explant that, and do the histology. If bone has grown around that material, in the absence of bone, by definition, that material is osteoinductive. calcium phosphates are osteoinductive. And what does that mean? If you start looking at some of the literature, in fact, a lot of the literature outside of dentistry, activation of the receptor by calcium triggers a cascade of events, including bone-derived cell lines. Cytosolic free calcium dependent of osteoclast bone resorbing activity. When calcium is present, it inhibits bone resorption. Journal of Cellular and Molecular Medicine, a clinically relevant model of osteoinduction, a process requiring calcium phosphate. Ectopic bone formation occurs around the calcium phosphate granules, so it's deemed to have triggered the osteoinductive program. And here is the study on dog dorsal muscle. Calcium phosphate has osteoinductivity after implantation without the use of bone marrow cells or growth factors. So it's a very powerful material if it's used correctly, focusing on gene expression as the basis of stem cell differentiation. Osteogenic differentiation of stem cells, meaning a stem cell that has not yet become anything. If it comes in contact with free ionic calcium, it becomes a bone-producing cell. And this is what we want. We want a cell, an osteoblast in this case, to reach the substrate, the bone graft material, and immediately spread out and start to communicate with each other. This increased activity occurs when the material is releasing free ionic calcium. How do we know that? When an osteoclast resorbs bone in a cutting cone, it releases two things. It releases stored BMP and calcium from the hydroxyapatite. Right behind it is an osteoblast, which follows it everywhere it goes. It spreads out. It's stimulated by those two things. It starts to produce bone. How powerful is calcium? Well, here's an orthopedic study with human osteoblasts, the MG63 line. That's classic for doing this in vitro and in the laboratory. A rat and mouse osteoblast. The white columns, that's how many osteoblasts there are when calcium is absent or in very, very small amounts. The black line is how many osteoblasts are present when the correct ratio of free ionic calcium is present. We can upregulate human osteoblasts by 500% if the chemistry is correct. Very, very powerful. How quickly do cells respond to calcium? Well, here's another orthopedic study that tested two different concentrations of calcium, 1 millimole and 5 millimoles. So 5 times that. Then tested it at 5 minutes, 10 minutes, 60 minutes, 2, 6, 24, and 48 hours. Calcium is so powerful that in the correct concentration at 5 minutes, we can actually measure an increase in metabolism of the mitochondria of an osteoblast. If you upregulate it that quickly, that's how quickly you're going to start to produce collagen, which then becomes bone. One of the few clinical studies you will ever see, these are on implants that have a calcium phosphate surface. And they did this in Italy, where they did full arch maxillary implants with the stipulation that 2 of them were going to be explanted at 2 months. And these are actually intralock implants with the osseous surface. This is what within the same patient, this is what an implant looks like with just an acid etched surface. At 2 months, average bone to implant contact, no real bone remodeling, a little bit of settling and loss of crestal bone. But in the same implant, in the same patient, the only difference this time is that they had a molecular impregnated calcium phosphate surface. We see something dramatically different. Look at the bone remodeling around the threads. Look at the percentage of bone to implant contact. In fact, look at the crestal bone position. Dramatically different in the same patient. This is the power of a calcium phosphate material. And if it's good on an implant surface, it's certainly good for me in my graft complex. So when we are placing implants, I love doing extraction median implant placement. This is the final drill. In fact, some of these cases, the defect is large enough, so we just go to a final drill. This is an Envision OS implant from Intralog. It's got a calcium phosphate surface. Into the gap, we place calcium phosphate, in this case, Cerasorb M. We just put one little suture in there just to close off the gingival margin. And then we re-enter this at 2 months, and we start to restore it. This is what it looks like at 2 months. Go ahead and remove and look at the beautiful tissue complex around here. But as beautiful as that looks, when we start to look at the radiographs, here's the radiograph, and then here's a three-dimensional representation of that radiograph. Down at the bottom of the apical half, average bone to implant contact, but in the gap, in the extraction site gap, look at the increased density of this bone that surrounds it. So this is a combination of a great surface of the implant plus Cerasorb M. So the free ionic calcium is contributing not just to early bone growth, but certainly to bone density. And that's extremely important to us in implant dentistry. Now, the next area I want to cover is the hydration process of bone graft products. And I've got a whole range of things that we have done through the years, some of which we realize today are not that great. And the first question I have for you is, how many of you have ever hydrated a bone graft material with sterile anesthetic solution? And when we don't have saline or anything, of course, we use sterile anesthetic solution. But the problem with that is that it's the least effective because it has a pH of 3.3 to a pH of 5. Why is that not good? Because if you drop the pH from physiologic neutral, which is 7.4, to even 7.1, a tiny drop of pH, you completely shut down something called the EGR1 gene in an osteoblast, which stands for early response gene 1. And as long as that gene is turned off, you will not produce bone. So you're starting off with a handicap by putting something in place that is very, very acidic. The next material, and all of us, of course, probably still use to some degree some sterile saline. It's a neutral pH, which doesn't really get in the way of what we do, but it has no growth factors. It simply gives us some better handling of the graft material to deliver it. And it really just using saline to give it better handling characteristics. But for any of you who have ever used a beta tricalcium phosphate product, you will note that on the box it says must be hydrated with the patient's blood. And that's because if you hydrate it with saline, the saline immediately goes to inside the pores of a graft particle, and the release of calcium is so high you actually get a calcium inhibition of bone growth. That first video that I showed you, where I perfectly executed that surgery, but when I reopened it, found a lot of fibrous encapsulated tissue. That's because in the early stages of the use of beta tricalcium phosphate, I was hydrating it with saline, which was wrong. And once I started hydrating it with at least whole blood, my clinical outcomes went up dramatically. The next one is going to be whole blood. At the very least, I don't care what graft material you use, you should have, number one, a bleeding osteotomy. And if you don't have bleeding, well, decorticate. Because without a bleeding site, you're not going to get a rudimentary blood supply. Without a rudimentary blood supply, you're not going to get regenerative cells. I'm sure that anyone on this webinar has experienced the following outcome, where you did everything perfectly and looked great radiographically, and you reopen 4 months later and found nothing but graft material, nothing turned over. That's because you didn't decorticate. And the worst offenders are removal of endodontically treated teeth, because it loses its connection to the pulp, loses its periodontal ligament, and then it becomes pure compact bone, lamina dura, which has no vascularity. So if you extract a tooth and look down and say, okay, bleed, and it stares back at you dry, well, you need to decorticate that. The next stage up from whole blood would be something called autologous serum. And for anyone out there who currently uses PRF, which is a second generation autologous material, you know that when you're producing, you're manufacturing your plugs or membranes, there's a fluid that forms in the bottom of your collection box. I love to use that because it has a pH of 7.4. It does have some growth factors that have already been released into the blood, and that's what you're expressing. So you collect it and hydrate your bone graft material. But the problem is growth factors that have already been released have a very, very short life in some cases. For example, platelet-derived growth factor only has a half-life of 2 to 4 minutes. After that, it's exhausted. BMP, circulating BMP, has a half-life of 12 to 24 hours. So after a day or two, it's exhausted. So we want something that carries more growth factors. Where do we find that? After using serum, if you want to get a decent hydration, it's a beautiful hydrating material because it's pH neutral. It makes your bone graft sticky, so it handles beautifully on a spatula. You pick up a little bit and you can turn the spatula upside down and it doesn't roll off like particulate material because it contains tissue adhesion proteins, thrombospondin, vitronectin, fibronectin, which is good stuff. Now we look at the use of autologous fibrin material, which we call autologous plasma. And it's most effective of all because it has a pH of 7.4 and it's the highest in growth factors. You just have to wait for that phone to go off. And autologous plasma is great because it contains live cells, which is a great material. So if we want to talk about something called composite grafts, a novel way to use our traditional graft materials, and especially highly bioactive TCPs in whatever form you want, I love to combine them with blood components, especially with autologous growth factors. Why do we do that? Well, if we want to look at the conversion of fibrinogen, which is circulating along with these cells, and then make a fibrin clot, it requires three things: thrombin, autologous thrombin, clotting factors, and free ionic calcium. And that's what we get with beta-tricalcium phosphate. So if you're going to use plasma, we'll spin down our blood tubes. We'll harvest only the yellow portion in this. Here we are just using an irrigating syringe, sterile irrigating syringe to take off the plasma. These are in white tubes that are only spun for 3 minutes. We don't want it to coagulate. We want it in liquid form. And we'll draw that off. You see a little bit of a red tinge in there. The red tinge are not red blood cells unless you mistakenly put your tip of your needle down into the red blood cells. But those are platelets, bright red. And we want to harvest as much of that without going into the red blood cell range. And then we hydrate our graft material with this. It makes it incredibly bioactive. So when we add growth factors to alloplastic materials, it upregulates vasculogenesis. You get a rudimentary blood supply that much more quickly. We have concentrated growth factors, the inflammatory cascade, and go more directly to anabolic bone growth. It's chemotactic for certain cells, means it attracts cells that will help us in healing. And we add platelets and the white blood cells, leukocytes, for the time release of critical growth factors that are involved in early bone growth, including BMPs. Now, if we want to look at certain defects, and we're going to go through a few of these in our clinical presentation, composite grafts facilitate the grafting process. They help to maintain ridge architecture. They resorb at the same time that autogenous bone is produced. They eliminate the need for membrane coverage in some of these cases. They achieve ideal bone mineralization, cost-effective, easy to handle, easy to place. So what are the 5 key scientific points for selecting a bone graft material? 1, the resorption rate better be ideal. And ideal is it resorbs at the same time as autogenous bone is laid down. Is the entire graft turned over into bone? That's what I want to see. I don't want bone graft material left over after resorption of the material. I want it to be easy. I want it to be predictable. I want it to look good radiographically and then look good functionally and histologically. It should show good vascularity and density upon re-entry. And we want to be able to place an implant as quickly as possible. In many of these cases, either 2 to 3 months, I'm going back in and after regenerating bone and place my implants, which is pretty much unheard of in using certain graft materials. So the question then becomes, and I'll just ask a few of these and then show you what I believe the answers to be. Do you use a non-resorbable bone graft material? Well, if you do, especially high crystallinity HAs, and the worst offender to me is xenograft, bovine, equine, porcine, because they're so highly sintered, so dense, they do not resorb. Not only do they not resorb, but they start to form scar tissue, they start to form fibrous tissue, you get an inflammatory response, multinucleated giant cells, and if you ever re-entered some of these cases, this is what you're going to find. You're going to find a whole lot of fibrous encapsulated graft material that is not bone. I don't want this, because if it becomes really fibrous encapsulated, it actually becomes bad for the bone. It actually causes more bone loss rather than regenerating more bone. And for these cases, you have to remove 100% of your graft material if you intend to regenerate anything around. Unfortunately, this defect, treated as a foreign body reaction, this defect was so large, all I did was unscrew the implant and it was gone. So I don't want to see you using a non-resorbable HA, from xenograft to high-density HAs as alloplast. So alloplast and xenografts look the same macroscopically, radiographically, and have pretty much the same handling characteristics, but after that, they're just about the same. When you reopen your grafted sites, do you find some soft tissue encapsulation instead of bone? Well, this is the reason why. When bone grafts don't resorb and the body starts to recognize them as foreign bodies, they start to wall it off. You have multinucleated giant cells, and you get sclerotic bone, not well vascularized bone, and a lot of connective tissue interface. Not a good idea if you want to place an implant here. If you're trying to just regenerate a ridge and keep it from resorbing, well, then you can use something like this, but not where implants are going to be placed. If you ever had an implant failure in grafted bone, well, perhaps this is the reason why. Because there's so much graft material that's left, you end up with a very, very low percentage of vital bone. If you use complete xenograft, you'll only have about 35% vital bone when you re-enter. It may not be enough if you have a high stress-bearing area. If you use a corticocancellous allograft, you'll have anywhere from 45 to 55% bone. If you use a highly resorbable calcium-releasing bone graft, you can end up with about 60-65% vital bone. And if you use that highly resorbing calcium-releasing bone graft material with concentrated autologous growth factors, you can end up with 75% vital bone. This is my strategy today. A pure phase beta TCP combined with autologous growth factors. Do you find a lack of vascularity in the grafted sites? Well, here's a typical sinus graft with a high sintered, high crystallinity bone graft material. Here's the implant placed. Good vascularity within the crestal bone, the bone that still remains, and no vascularity within the grafted site. And you want a failure in posterior maxilla, this is the reason why implants fail. Give you an example. I don't know if anyone has ever had the opportunity to re-enter a BioOS grafted sinus. Well, here's a case where I actually did revisions, bilateral sinus revisions. And you can see a lot of dense graft material that still remains after 2 years. So here is the upper left side. I went ahead and did a lateral wall window, your typical lateral wall approach. But it's not an open sinus, it's just going to be graft material inside. And this is what a xenograft grafted sinus looks like. You wonder why it looks so funky on a radiograph? Well, this is why. It is not bone. It does not have vascularity. And if you put your implant in this stuff, don't expect your implants to survive because this is not bone. It's pure, walled off graft material. You'll be able to see in a moment as I peel out the material, this is not bone. So I don't know why people continue to use this in sinuses. Once you remove it completely, then we're able to once again lift the membrane and then put a graft material. In this case, I did use Cerasorb M, hydrated and autologous biologics, and delivered here, and these cases heal beautifully. It's interesting because if we look at some of the high-profile names attached to some of these newer studies, this is 2013. One of them happens to be a gentleman, a periodontalist from Connecticut, Stephen Wallace. Now, Stephen Wallace, 20 years ago, wrote a paper at New York University with Dennis Tarnow and Stuart Frome and a bunch of the big, high-profile guys up in the New York area. And their whole thesis was that implants are highly survivable in sinuses grafted with a xenograft. And the one flaw in their study was that they still had a decent amount of crestal bone present. And we know that the loading of an implant occurs at crest, not in the apex. So it was kind of a false positive for them. But it's interesting that years later, Stephen Wallace, the guy who's been lecturing for 20 years on sinus grafting and using xenograft, in this paper said that they did a lateral wall window approach in 11 patients, and at 6 to 8 months, they did the histology on that. What did they find? Histological evaluation revealed the newly formed bone to be mostly woven bone. At 6 to 8 months, not a good strategy if you want survival of your implants. Another paper, which includes Linda, and they found that the placement of biowas collagen in fresh extraction wound delayed socket healing. Bone cells do not like foreign material that's not resorbable. It doesn't contribute to bone growth. It's not osteoinductive. So don't use xenograft in areas where you want to place your implants. And this is what it's going to look like when you open it up. There's a whole lot of particulate that's still here. I enjoy watching some clinicians when they reopen these things. And for the American participants tonight, you know what hamburger helper looks like. Well, this is the bone graft equivalent of hamburger helper. It's just a whole lot of graft material with a little bit of bone interspersed between the particles. There were many studies done, over 200 studies done on beta TCP, and in particular the Cerasorb product, because it's been around the longest. And if we look at the body's own cells, which is autologous bone, the next highest bone growth percentage occurred with pure phase beta TCP from Cerasorb. That's what I want to see. A bone graft material that gives me as close as possible the kind of clinical outcome that you get with autogenous bone. And that leads us into a discussion of something called repair versus regeneration. Because repair is the filling of a defect, whereas regeneration is the regeneration of the bone complex that was previously lost. When you use a non-resorbable hydroxycrapatite, you get repair. It fills in the space. When you use a highly resorbable calcium-releasing material, that is the true definition of regeneration, because we want restoration of the functional tissue complex, especially if we're going to place a loaded dental implant. The histology studies. Spongiosa, which is autogenous bone, look at the amount, look at the percentage of bone in the beta TCP, almost identical to autogenous bone. That's what I want to see. And these are 20 split mouth studies. So you can't say, well, it might have been the difference from patient to patient. No, within the same patient, split mouth, autogenous bone graft, and alloplast, calcium-releasing alloplast. It's almost identical. So why do I need the morbidity of a secondary site when I can use a beautiful, pure alloplast, calcium-releasing bone graft and get almost identical results, clinical outcome? Do you want a graft material that heals more quickly and gives you greater bone density? Of course you do. You don't want bone density at 35%. Minimum should be 45, 50%, and higher if you can achieve it. That's what we achieve with these graft materials, especially when we add autologous growth factors. What's the preferable outcome? This, with a lot of big bone particles and a little bit of bone in between. And look at this connective tissue now. A lot of connective tissue. In fact, around xenografts, you have the highest percentage of connective tissue. Connective tissue is not stress-bearing. Sorry. Or do you want vital bone and bone osteons forming in the degrading Cerasorb granules? Here's a Cerasorb granule right here that's forming bone externally and then internally within the granule until the entire granule is gone. Look at the quality of this bone. That's what I want to see. And we've already covered these two. Let's now look at a lower right mandible with a knife-edged ridge ramped through the facial. It's missing the facial incisal line angle. It's down to basal bone. It's got good height. It's a BW ridge. And we want to place 2 wide diameter implants for molars. I don't care what your technique is to maintain your volume. I've used them all, from collagen membranes to titanium reinforced PTFE membranes to titanium mesh. In this particular case, I'm going to use tenting screws. Tenting screws are off the bone about 5 millimeters. How do we know that? Well, in a moment, you're going to see the assistant bring a suction tip in. And the suction tip is 5 millimeters in diameter. It goes below the head of the screw. So that's 5 millimeters. Here's a beta TCP graft hydrated with autologous serum, covered by a collagen membrane, and then covered with something called a PRF membrane on the top. So we get good, quick closure and anastomosis for our flat margins. And then we try also to get good primary closure. So we do a periosteal release on these cases, so we don't have any extravasation of our bone graft material. Then we re-enter. I don't care whether you enter 4, 5, 6 months in these one-wall defects where there's a lot of bone to be reformed and only one wall to grow from. I like to wait about 6 months because these are pretty large grafts. When we reopen, we see something remarkable. The one thing you do not see here, you do not see particulate. This is 100% vital bone. In fact, there's a cortical bone layer here that's reformed. This right here is the original ridge from this line back to here. This is all grafted bone. This is a 12 millimeter wide grafted area. And watch when I remove the tenting screws, look at the vascularity of that bone. Grafted bone, that's what you want to see. You don't want to see what looks like dead bone internally. When you remove that, look at the bleeding site. And then when I'm drilling my osteotomy, look at the vascularity. When I actually pull the drill out, you can see. Now, this is a grafted complex. And grafted complex, especially if you have a lot of graft material that's still there, still resident, you're not going to get a lot of vascularity. But watch when I pull the drill out. Look at that vascularity. That's grafted bone. That's what we want to see. This is the regenerated, not just hard tissue, but soft tissue complex to 6.0 millimeter implants. This is a 1-year post-op on this case, showing beautiful retention of the keratinized tissue zone and the volume of this. But what we don't see yet is that these two anterior implants are implants as well. This is the radiograph. And these first two implants were actually extraction, immediate implant placement. So the average bone density, bone to implant contact, is pretty good because it is, after all, an extraction site. It was under function, so it has good minerality and density. But now look at the density of the bone in between where the implants were placed. The density of the grafted area is actually better than the density in the extraction immediate implant area. This is the power of a beautiful osteoinductive calcium-releasing material, especially when you hydrate it with autologous growth factors. And this is my strategy today. In just about every case, I'm going to use a good beta TCP, and the one I use is Cerasorb M. I've been using that for over a decade. Hydrated in autologous serum and or autologous plasma. So if we now go down our list and say the comparison of xenograft versus allograft, it's a low rate of resorption to almost non-resorbable if using a xenograft. It's a filler only. It's only osteoconductive. If it's not releasing free ionic calcium, it can't contribute to bone growth. And because there's a lot of graft material that's left, it reduces the rate of neovascularization. There's little or no release. Maybe there's a little bit of release of free ionic calcium from the allograft, but certainly not from the xenograft. So you end up with a lower percentage of vital bone, lower stress-bearing modulus, may become fibrous encapsulated, especially if there's a foreign body reaction. There's a potential for a risk of disease transmission, and you get repair, but not regeneration of host bone. And if you compare that now to a beautifully pure and completely resorbing beta TCP material, which is Cerasorb M, it's highly resorbable. I want that material to be gone after it does its work. It's replaced by autogenous bone at a very rapid rate. In fact, the same rate as autogenous bone is laid down. It does release free ionic calcium, and at the perfect speed that upregulates cells, it increases the number of osteoblasts present in the regenerating site. So you end up with a very high percentage of vital bone. And because of that, you actually can re-enter these sites earlier. You have a much higher stress-bearing modulus because of the increased density. There's no foreign body reaction, no risk of disease transmission, and for this, you do get true regeneration of host bone. We want regeneration, not repair. Over the past couple of years, I've had the opportunity to be involved in a research project for one of the newer products in the Cerasorb line. And I understand it's probably close to market right now. It's called Osteolive. It is a beta TCP, but it's doped with a silica-based material. So it's a silicated calcium alkali phosphate, and this speaks to a particular part of the bone growth cycle. And I'll tell you what, as good as beta TCP is, I'm amazed now at the results that we're getting with Osteolive, because the silicon part of this has a vital role in assisting calcium in bone growth. And because silicon increases the amount of collagen, and we want the first things that osteoblasts lay down is collagen, which then undergoes a precipitation reaction and then becomes bone. So if silicon is increasing the amount of collagen produced by an osteoblast, obviously we're going to get earlier bone and a greater percentage of vital bone when we do that. Here's an example of what the Osteolive granules look like, very, very close in structure to human bone. So when cells reach it, it's going to react virtually the same way because it is a calcium phosphate, which is close to the HA of natural bone. It's going to react pretty close to normal. Here's an example of a micro CT at only 3 months, a very large amount of graft material, but at 3 months, almost all the particulate is gone. That's what we want to see with this material. And silicon activates something called the prolyl hydroxylase enzyme, and that enzyme is what governs the formation of bone and the mineralization of bone. So it's a very, very powerful thing. In fact, a lot of bone graft materials are moving towards the doping of their granules with this material because it certainly speeds up bone growth. So we're going to make it super bioactive by taking some of this autologous plasma. For the PRF users, it's a white tube, so it only spins for 3 minutes. We have the tip of the needle right down in the brighter red area. The brighter red area has a preponderance of platelets, not going down into the deep red, which are erythrocytes. We don't want those, but we certainly want the brighter red, which are the platelets. Then we're going to take this material and we're going to take our osteolive. That's what it looks like. Just a little tinge of pink in it, the bright red. That's what you want. We're going to hydrate our graft materials with this. And it's not just wetting it for better handling. After about 15, 20 minutes, it actually becomes a plasmatic membrane. It hardens. So instead of bringing particulate to the graft site, it actually forms a little bit of a fibrin plug. This makes the handling far, far better. You're not going to lose your graft material in the mouth. I'm sure you've all done that. And especially if it's a critical area, you're running out of bone graft material, it falls on the tongue, and when no one's looking, you pick it up off the tongue and put it back in your extraction site, and you're introducing another biologic component, which is bacteria. But this is great because it allows us to bring it to the site and handles beautifully. Here's a vertically fractured tooth, highly infected. Let me go back to it. That was a video. Let me start again. This is a vertically fractured tooth, highly infected. We're going to do the surgery to remove this, and when we remove it, you're going to start to see. Here's a lot of mobility of the tooth, a lot of granulation internally. You do want to debride these entirely. You cannot leave any granulation tissue present. All of that must come out. Then I don't care how you debride the area, just do it completely. Now here is the fibrin complex with the osteolive. Note that it's not true particulate anymore. It's got a fibrin base to it. It's much easier to handle. You can bring the whole complex to that, and it doesn't extravasate like individual particles do. You go ahead and compress it down lightly, not a lot. You don't need to really compress it hard. And then you just use a membrane over the top of this. Just gently compressing it. And then whatever membrane you like from there. Here's an example of a periodontal defect. This is a long span bridge on a mesially tipped molar, and you've all seen those defects on the mesial of these tipped molars because you can't keep it clean, you can't floss, you can't get in there. So we're going to debride all the granulation tissue. And again, you must do this completely. And there's going to be a few different instruments in here. I love to use lasers for this. I find that the debridement with a laser is not only very, very effective in removing any shreds of tissue tags of granulation tissue, it also helps me to decontaminate it through a direct laser action and through something called the photoacoustic effect, the shock of the laser going on and off in an erbium-based laser. This is from BioLase, the WaterLase MD, or the WaterLase I+ now that I'm using. Okay, and just make sure that you've removed all of that granulation tissue. And then we're going to take our bone graft. Now this is not osteoid, this is actually normal Cerasorb M, beta TCP. I've used a little bit of autologous plasma. After 20 minutes, it becomes a hardened mass. Now it's easy to take one of these pieces of bone graft material, bring it right into the site, and then just go ahead and compress it right down into the defect. It packs just like any collagen would. It's amazing. It handles so beautifully. And after after you pack it completely, making sure there's as few voids as possible. It doesn't matter if there's a little bit of a void in a very, very apical part. As long as there's bleeding, that clot will work just as effectively as the graft material that you're placing. And then just readapt the tissue using a good suture technique, especially circumtooth to keep the ridge tissue closed. And then just readapt the tissue here with a good suture technique. This is the site on the day of placement. You can notice the bone graft here. I don't care that there's a little tiny void right here because that's filled with a blood clot. And blood clot will work very, very effectively if it's protected. So here's the Cerasorb on here. And this is a 3-month post-op. At 3 months, there's no longer any particulate. Look at that bone. It's all bone. You can actually see the cortical bone regenerating right here. This is what I want to see at 3 months. So it's occurring far more quickly with far greater bone density than I could ever achieve before. So good calcium-releasing bone graft material with autologous growth factors gives us the best clinical outcome. Periimplantitis. I've been treating periimplantitis for almost 20 years now. And I've always had a problem in some cases with the amount of bone that's being regenerated. Well, that's because I was probably using the wrong graft material. Plus, I didn't have the kinds of instruments that we have today, which includes ablative lasers to remove not only the granulation tissue that's present, but also to surgically debride the implant surface. On these roughened surfaces, I find again that my best instrument for this is, in fact, an ablative laser. 2004, we published a paper in the Journal of Oral Implantology that shows how effective on a scanning electron microscope study we were able to surgically debride these. This is the I+ from BioLace. Then we're going to graft this as soon as I'm finished removing any trace of this granulation tissue. Now I'm going to deliver the Cerasorb product, the Cerasorb M, hydrated and autologous serum. This was prior to our using the fibrin-based, but as long as you're using some kind of autologous material, whole blood, serum, or even plasma, it doesn't matter to me. Then we use a little bit of a membrane to cover that up. And then I have a 2-year post-op on this case. There's my 2-year post-op. Good bone regeneration, no suppuration, good soft tissue complex. This is what we want to see. So in conclusion, Cerasorb is both osteoconductive and osteoinductive because of the release of free ionic calcium. You get complete resorption of the Cerasorb granules in new bone. We have an ingrowth of the Cerasorb granules by bone cells and blood vessels for a 3-dimensional resorption inside and outside of each granule. So the 3-dimensional means it's going to resorb more quickly. And the Cerasorb degradation occurs with simultaneous bone replacement, resulting in a very, very high degree of mineralization and density. That means we get regeneration, not repair. We want regeneration because we want the highest density of bone, the highest minerality of bone, and we want stress-bearing lamellar bone to grow more quickly. And we can do that with the use of a good bone graft material, in this case, pure phase beta TCP, autologous growth factors. So I'm going to end my presentation there, and we have another few minutes for which we will entertain some questions. I'm going to exit out of this. All right, let's go now to, let me exit out of here. All right, so I have Number of questions. Let's see how many we have here. Not too bad. I think we can get through all of them.
Where would you? That about the speed of the centrifuge as well as confirming the minutes.
Okay. The speed is the same speed that we use for PRF. It's 2,700 RPM, but it's only 3 minutes. It's only in a white tube. We do not use red tubes for this because if you use a red tube, it's going to form a fibrin clot at 3 minutes. We want the liquid portion of this. So it's 2,700 RPM, no different from the red tube spin, but only 3 minutes.
And you can ask them to enter their questions in the chat box.
Yeah, let's go ahead now and let you post any questions for me in the chat box here.
Let's. How long do you wait after grafting the Cerasorb M?
The Cerasorb M, how long I wait before I re-enter? That's easy. When we take a radiograph of Cerasorb M, you will see granularity. You'll see the Cerasorb granules. And in fact, in one part of the Osteolive clinical trial, we had to take periodic radiographs and then note at what time that granulation, that granularity disappeared. So I'm re-entering routinely at about 3 months in my graft cases, and I'm getting excellent bone quality at that time. Whereas most people would have waited 4, 5, or even 6 months to re-enter, and this is something that we are very confident about because we've done so many cases in the past. What is our next question here?
Again, if you have any questions, feel free to enter it into the chat box.
It says same tubes. No, the same. We're using fibrin-based material. We're going to use the red tubes for anything that's fibrin-based. Anything that's liquid plasma-based, we use the white tube. We do a 12-minute minimum 12-minute spin for the red tubes. For fibrin-based, we use a maximum of 3 minutes on the white tubes. Do we have any other questions?
One, is there a difference in wait times for Cerasorb M and Osteolive?
There's a slight difference in wait times. I found that I actually get a decrease in the number of granules present when I use Osteolive because as a silicate doped material, it's actually speeding up the process of new bone growth. So it's slightly faster. Is it clinically significant? In a big graft complex, I would say it is, but in a very, very smaller grafted area, probably not. And what we're looking for anyway is radiographic evidence of bone growth. I want to see the granules disappear. Once the granules have disappeared, it means that it's replaced with autogenous bone. And that's going to be the arbiter of when I'm ready to re-enter.
Another question, can you do an immediate implant with bone augmentation with Cerasorb M?
Oh, that we do routinely, especially, but remember, you need good initial stability. Initial stability comes from whatever host bone is left. If you get good initial stability, then placing Cerasorb in the gap area is ideal for me because bone cells will bridge that very, very quickly. You'll get excellent mineralization, as I showed you in one of our cases.
Okay, again, if you have any questions, feel free to enter them into the chat box.
All right, and we have any other questions here?
Okay, do you want to stop your sharing and then